Hi, everyone. Good morning. It's really a pleasure for me to be here with you today to talk about the Rich Life Project, but also this is my first time attending this conference, so I'm really excited to be here. My birthday's next week, so this is like an early birthday present. Thanks. Thank you. I can give you my address after to send me gifts. I'm accepting cars, jewelry. No, I'm kidding. I'm not doing that. So I'm hoping that in this presentation, I will try to summarize some of the core components of the Rich Life Study, and then to talk about the participatory approaches that we're using, rather, I should say, throughout the life of the study itself, which is still underway. It actually ends next year. And then to talk about best practices associated with stakeholder engagement or stakeholder engaged research. I really think before we start to talk about the Rich Life Project, it's good to have a definition of stakeholder-engaged research, and this definition comes from the Patient-Centered Outcomes Research Institute. What stands out about their definition is the way that they discuss how stakeholder-engaged research is characterized by meaningful engagement, so not tokenism, which I think a lot of us who are involved in research are well familiar with when we think about how different partners are engaged, but that people are involved and relevant stakeholders are involved throughout the life cycle of the study itself. And then as well, there's a commitment to disseminating and translating the findings of that research into practice. So it's not just research for the sake of it, but research to advance a specific end. And on a personal note, I just would like to thank and acknowledge Dr. Janice Bowie, because she was my doctoral advisor when I was a student at Hopkins. And I really look up to her for doing this type of research, and it's the kind of work that I'm striving to do in my own work right now. I think this slide that kind of summarizes the trajectory of stakeholder-engaged research is probably familiar to a lot of you. If not the slide, at least the steps that it encapsulates. So the things that are listed in the boxes are the things that we typically associate with conducting research. You identify a health concern, you seek funding to support being able to develop something to address that health concern, you recruit participants, and you also hopefully try to develop strategies to retain them throughout the study. You design the measurements and data collection strategies, then you go into intervention design and delivery, and then you analyze the findings. What makes stakeholder-engaged research distinct from other types of research is that at every step of the way, there are stakeholders involved in executing that particular step. So for example, with the identification of health concerns, that you have stakeholder participation in doing so. When it comes to measurement instrument designing and data collection, that you do these things with stakeholder input involved in the actual construction of the measurement and then thinking through how to collect the data. And I think the last step is also very important, that stakeholders are involved in actually interpreting and then disseminating and translating the findings. So with that being said, I have the pleasure of being a co-investigator of the Rich Life Project. And the Rich Life Project stands for Reducing Inequities and Care of Hypertension, Lifestyle Improvement for Everyone. This is a study that's jointly funded by PCORI and the National Heart, Lung, and Blood Institute. And they are funding it through the Hypertension Disparities Reduction Program, or the HDRPP. And it's one of two patient-centered studies that are really geared toward reducing disparities in high blood pressure. The picture that you see below is from our kickoff meeting, which was nearly 3 years ago. And it is made up of all of the different health system leaders who are there, as well as staff who are associated with the Rich Life Project and faculty as well. So this is a cluster randomized trial, and it occurs across 30 primary care sites that comprise a blend of federally qualified health centers and practices that are affiliated with an academic health center, Johns Hopkins Community Physicians. So we have 5 participating health systems, and we randomize some of them to receive a collaborative care or a stepped care intervention while others were randomly assigned to the standard of care plus arm. And we're in the midst of trying to recruit about 1,800 to 1,900 patients who are non-Hispanic Black, non-Hispanic White, or Hispanic, and have uncontrolled hypertension. We're comparing standard clinical performance feedback and education for providers and staff to the stepped care arm, which is in essence a nurse care manager, a community health worker, and a primary care provider. So a team-based multidisciplinary care where the nurse care manager is kind of the quarterback of the team and helps to designate the additional support that a patient may need. So if the patient needs support regarding different social determinants of health, then the nurse care manager will involve the community health worker in helping to support the patient. And they also help to figure out whether or not that patient requires additional support from subspecialists. And the way that this need for support is identified is whether or not they're able to achieve blood pressure control within a specific period of time. So it's called stepped up because in essence the patient is stepped up to get that extra help. And then of course we have the outcomes that we're analyzed at both the patient level, but then also some subgroup analyses by race and ethnicity. And you can see what those outcomes are, both biomedical and patient-reported outcomes. This slide just shows some of the health system partners that are involved in this project. And we have Chop Tank, which is located in the Eastern Shore, which is a more rural part of the state of Maryland, for those of you who are not from this area. We also have Berks Community Health Center, which is in Reading, Pennsylvania, Total Health Care and Park West, which are both located in Baltimore City, and then Johns Hopkins Community Physicians, which is kind of dispersed throughout the state in various types of geographic settings. What we've really tried to do throughout this study is to borrow from what Dr. James said earlier, trying to infuse stakeholder engagement throughout the course of putting together the study and then implementing it. So one of the things that I do is, as was mentioned, is that I'm the Associate Director for the Center for Health Equity's Stakeholder Engagement Corps. And I have the privilege of working very closely with our Community Advisory Board, which is made up of dozens of members from all different backgrounds. And our Community Advisory Board was instrumental in helping us to think about how to conceptualize this type of multi-level, multi-component intervention. For instance, I think in a lot of different studies, the focus is on one particular disease. What we've tried to do with Rich Life is to say that, hypertension may be the main outcome that we're exploring, but if you have other conditions, we're also interested in patients who are struggling with other chronic ailments that are related to high blood pressure control. And that idea really came from the Community Advisory Board, who also weighed in on the study's instruments, on some of the intervention data collection that we put together for the nurse care managers and community health workers. And several CAB members actually helped train the community health workers and nurse care managers. So as you can see, that's a little bit of background about the CAB. The other thing that we have as a part of this project is we have a lot of different meetings that are supposed to be in close collaboration with those who are leading, who are either implementing the interventions at these respective healthcare practices or are leading them. And so we do this through coaching calls, we do it through our Health Equity Learning Network, and a number of our health system partners actually attend some of our CAB meetings. And that really speaks to the second point of co-learning, that we try to advocate for co-learning through the mechanisms that I mentioned above, the Health Equity Learning Networks, just consistent phone calls and opportunities to either visit these practices ourselves or for them to come to us. We also are really trying to cultivate and sustain strong partnerships. And I think this is one of the most critical pieces of what this study is aiming to do, because as I mentioned before, the Rich Life Project ends next year, and with it, the funding to support some of these interventions. And so the real hallmark of our success is going to be whether or not the healthcare organizations who have been a part of this project will be able to sustain key components of these interventions, and whether or not only from a resource perspective in terms of money, but also will there be the will within the organizations to maintain the things that came up through this project. So we're in constant communication, and this has proven to be one of the most important strategies, in part because of different priorities, shifts in the staff, and that sort of thing. So this has been really helpful for us, as well as this idea of transparency. So we keep our research study team meetings open to our CAB members, to those who are participating in the study itself. And we actually try to leverage some of these meetings as a way for people to learn more about the study and to learn more about what types of things are happening on site for them, so that we are on our own are kept abreast of what's happening, but they also have a strong entry point to contacting us. I mentioned this earlier, that one of the things that we have is this whole health equity learning network. And so these are interactive quarterly webinars that are, oh no, what happened? Thank you very much. Sorry about that. So we have our Health Equity Learning Network, and so they are including a brief didactic presentation and then opportunities for peer learning. So what will happen is, so as an example, I did a Health Equity Learning Network session for some of the Rich Life health system leaders. It was really fun. I did it with one of the practices that's part of the Johns Hopkins Community Partners, Community Physicians, so Remington. And they have this kitchen that they're trying to do in the Remington neighborhood, which I don't know how familiar some of you are with Baltimore, but Remington is rapidly gentrifying. I mean, it wasn't, and then all of a sudden it did. And so so what is happening there is that with Remington and that particular practice, they moved their physical location to a different building. The building that was constructed was kind of in the heart of Remington. It caused a lot of consternation among the neighbors and other community members who reside in Remington. And one of the physicians really wanted to at least use this new physical locality as a means of building relationships with different community members, and so had this idea of having this kitchen in partnership with a local church. So what we did for our Health Equity Learning Network was just to talk about how can you use these more local community-based approaches to build partnerships and to build, or rather, I guess, try to advance health equity even from a local perspective. And it was really fun. So when we did that, we presented on what we were doing, but then we also had opportunities to field questions from those who were participating in it. And then we have our coaching calls. So our coaching calls are a great way for us to maintain a sense of what's happening on the ground. They'll call in and they'll talk about what's going on, and we can try to respond with some technical assistance. But also, I think for those of us who have had the opportunity to be a part of these coaching calls, we learn as much from our health system partners as we hope they're learning from us. So I wanted to kind of highlight one of the particular healthcare organizations, one of the health systems that's a part of the Rich Life Project, because some of what we did in partnership with them was a little bit different than what was happening for some of the other health systems that are part of the Rich Life Project. So Park West, as I mentioned before, is based in West Baltimore. And they had a lot of concern around their hypertension outcomes. So that was one of the things that attracted them to being a part of the study. The other important thing to note is that their medical director was actually a longstanding member of the Community Advisory Board. So when this opportunity, this PCORI and NHLBI funding came up, he was kind of well poised to be a part of it, having already established a very good relationship with the center and with the broader community advisory board. So at Park West, they didn't have a lot of experience with community health workers. In fact, they had never had community health workers. And this is pretty common for a lot of the FQHCs that we have worked with, where they have a community health worker, but it's for a specific disease, and usually for HIV/AIDS, and not for chronic disease management. And so what we were able to do, again through our CAB, is that the Community Advisory Board, it is co-led by the center's executive director, Dr. Lisa Cooper, and Reverend Deborah Hickman, who is the CEO of Sisters Together in Reaching, a local nonprofit. STAR has extensive experience hiring and retaining and deploying community health workers. So we linked STAR up with Park West, and so 2 of their community health workers are actually working with Park West. And so their hope in being involved with the Rich Life Project is to take some of the things that they've learned as a result of their engagement in the study and apply it long after the study has ended. But of course, with any partnership, there's a lot of challenges and a lot of successes. So this first one, convincing the board of directors to get involved with the study, this is actually something that happened to a number of the FQHCs that we approached to be a part of the Rich Life Project. And I just am curious to know if any of you can hazard a guess as to why we had some trouble.
Control. It's control.
Yeah,
And not trusting.
yes,
The university. It's trust.
right.
Relationships, and all of those issues.
So it was definitely trust, and for better or for worse, to be quite frank, a lot of it is because we were Hopkins. And Hopkins has a troubled relationship in East Baltimore. And I don't want to suggest that that's the only thing about Hopkins. There are people in East Baltimore that really like Hopkins, and I don't want to treat it as a monolithic group. But we can't pretend that that tension doesn't exist. And so we really had to make sure that the members of that board were on board with being a part of this study, and that they knew that we were committed to these principles of participatory research. The other thing, too, though, is that I think Dr. James put this so well when she talked about the realities of doing health equity and health disparities work, that there's very few resources allocated to support these projects. So, it's wonderful that PCORI and NHLBI were willing to put forth millions of dollars to support this multi-level, multi-component intervention, and to do it at 2 sites. The problem is that even though it was a lot of money, it's still actually not enough money for some of the organizations that we're partnering with. And we found that it wasn't, we did try to give those who were what we call our practice champions and different health system leaders, we tried to incentivize financially their participation. It still wasn't enough for the level of involvement, because in any type of partnership-driven endeavor, it's a little bit easy to underestimate just how much time it will really take to stand something up, especially to stand up new interventions. So that was one of the things that we encountered. But I will say, I think all of us are grateful for the commitment that different health system leaders have exhibited to being a part of this. I mentioned earlier that this is a hypertension-based study. Even though we are interested in other conditions, it's still driven by whether or not a patient has high blood pressure and issues controlling it. And so one of the things that we learned from our Park West colleagues is that it was difficult for them to be involved because they try to treat everyone, irrespective of the condition that the patient may have. Whereas we're kind of imposing something based on the study, which was, do they have high blood pressure and these other conditions such as diabetes or depression or issues with smoking cessation. So they had some trouble wrestling with the issue of this fragmented care being delivered, and that people could be left out of what seemed to be such a great project by virtue of not having high blood pressure. But there are other things that they did appreciate about it, and one being that one of the things that the Rich Life Project does is to go out to different sites and train staff on how to properly measure high blood pressure or blood pressure period. And so that level of staff education that was provided was highly valued by them. They also appreciated the additional support that was given to those who are members of collaborative care practices. And then another key feature of the Rich Life Project is the IT support that was conferred just by virtue of being a member of the study through dashboard development. So this slide is very colorful because I like colors, but the other thing about it is that I am trying to also demonstrate some of the barriers that we encountered and then some of the ways that we tried to overcome them. And so I mentioned, or I alluded to this earlier, that there were competing health system priorities and limited resources. And so, you know, we try to be as keenly aware of that as possible. And of course, we're not perfect by any means. But I mentioned earlier that we tried to take advantage of existing meetings to maximize the time that people had to meet with us. And we, on our end, because this is something that is a little bit easier for those of us in academia than those outside of it, we tried to maintain some flexibility in terms of our schedule so that we could be available to address any questions or concerns they had as they came up. Something that I think we're all very well familiar with is leadership turnover and staff turnover. And this is where our attempts to be flexible and to maintain consistent contact really paid off, because we found that even within the past 2.5 years that this study has been underway, we've already seen, you know, medical directors come and go. We've had community health workers, nurse care managers, and other staff come and go. And so maintaining consistent contact with everyone, whether they are just starting or they're kind of midway through their tenure in the study, has been really critical, because that means we're able to stay ahead of these turnovers and kind of minimize their impact, at least on the project and on the patients who are part of the study. We definitely had some difficulties with the intervention uptake, one of them being some challenges around stepping the patients up to the community health worker. And so what we tried to do to combat this was having as many meetings as possible, again, not to overburden anyone, but just to find out what's going on the ground, what are some of the things that are happening that are on the horizon for you that we can be attentive to, and also changing the way that we framed things in a language that was more palatable to our health system partners and to our community health workers and care managers. But I think when it comes to stakeholder-engaged research, it's not just the Rich Life Project. There are just some broad considerations that, generally speaking, one should be aware of. Whether or not the agenda that we're coming up with is truly community-driven. And that's something that we had to we're constantly kind of navigating this and negotiating this relationship between how much of what we're doing is generated by us as a study team versus something that's identified as a need by the communities that we work with. We also can't deny the fact that there is an inherent power imbalance in research, and a lot of times researchers seize the power and aren't aware of the ways in which they're doing so. So we try to the best of our abilities to acknowledge this, to be transparent, and to kind of operate to the extent possible more horizontally than vertically, if that makes sense. And I think that really speaks to trying our best to exhibit some level of cultural humility, acknowledging that a lot of the patients that we're working with and the health systems that we're working with are in communities that have been traumatized by racism, by sexism, homophobia, all kinds of isms, and we can't be ignorant of these things. And we also can't pretend that we're not who we are, which are Hopkins researchers, and that there's a whole history and a lot of assumptions embedded in that. And so we are really committed to, and I can say this pretty confidently because it's something that we talk about as a research team, and we try to talk about it openly in our community advisory board meetings. of just talking through these things and being as frank as possible about these realities, but also that we try not to hoard the time that when we spend with our stakeholders, that they feel that they have opportunities to share what they're thinking. These are some ethical considerations, and some of which I already kind of touched on. It takes a lot of time to do this work, not just for researchers, but for the stakeholders too. And we really need to respect the time that stakeholders, whether they're consumers, leaders of health departments, or leaders of health systems, it takes time. There's a burden on people who engage in this work, whether it actually doesn't even matter what spectrum they fall on. It can be burdensome. The potential benefit is something that is not always clear, and there's a constant need to strike the balance between, especially in the context of research, between producing results that people find interesting and compelling, but also doing things that actually advance health equity in underserved communities. And one of the things that I struggle a lot with personally, I don't know if others can relate to this, is this idea of differential financial benefits, where when we apply for a grant, let's say from NHLBI or PCORI, a lot of that money goes to us. Like it funds staff, it funds faculty, and we may incentivize a community advisory board member to come to a meeting. But I'm happy to say that some of the work that we're starting to do, there's been a shift where we're actually giving the money to organizations themselves and not just to members of a study team. But there's still some work that needs to be done in that arena. So in conclusion, these are just some of the things that we have found to be really critical to doing good stakeholder engaged work, that communication, and look, if you look at this slide, everything that makes a good relationship makes good stakeholder engaged research. So this shouldn't be a surprise to anyone. If you treat people poorly and you speak poorly to them, they're not going to trust you. If they don't feel a sense of shared power in the context of the decisions that are being made, you're going to undermine the relationship that you think you're trying to cultivate with them. The same goes for trust and trustworthiness, respect. But I think this concordance in values is a really important note to end on, which is, to what extent do you all have a shared sense of what you're trying to achieve together? So I just wanted to acknowledge the wonderful people who have been involved with the Rich Life Project. There's so many more that can be listed, but I am highlighting the co-principal investigators, the senior research program manager, and then our excellent community partners at Park West. So thank you very much for listening to me talk, and I look forward to talking about this some more in our discussion.